This is a small worksheet that I have devised to interpret ABGs. It has got the steps and the rules on the left upper corner, on the left lower corner, the compensatory equations, and the diagnosis panel in the middle. You can print it and use it for practical purposes in your hospitals. Let's add ABG strip to it now and start interpretations. ABG 1. Step 1. pH 7.49, so upwards, hence alkalosis. Step 2. pH and carbon dioxide directions. Carbon dioxide is 29, so down going. So pH and carbon dioxide in reverse, and the RE of reverse stands for RE of respiratory. So it is primary respiratory alkalosis. We can see bicarb is 22, so normal meaning uncompensated. But we will utilize the equations of compensation so that in more difficult scenarios you appreciate the anomaly better. So expected pH for acute respiratory alkalosis as per formula is 7.4 plus 0.008 into change in carbon dioxide, it is 40 minus, what's the carbon dioxide, 29.2. So 7.4 plus 0.086, approximately 7.486 should be the expected pH of acute respiratory alkalosis for this patient. What's the actual pH on ABGs? 7.49. So this is acute respiratory alkalosis with no compensation or uncompensated. ABG 2, pH 7.329, so downgoing, so acidosis. Step 2, pH and carbon dioxide. Carbon dioxide is 68 millimeters of mercury, so upgoing. Now pH and PCO2 are in reverse direction, so it is respiratory origin, hence primary respiratory acidosis. Now next is compensation part. Bicarb is at 31.6. For acute uncompensated respiratory acidosis, the expected pH should be 7.40 minus 0.224, so around 7.176. For chronic compensated respiratory acidosis, the expected pH should be around 7.40 minus 0.084. So expected pH is 7.32. What's the actual pH on ABGs? 7.32. Hence it is fully compensated chronic respiratory acidosis. ABG 3. So first step, pH 7.55, upgoing, so alkalosis. Next step, the directions of pH and PCO2. CO2 is 19.5, so downgoing. So pH and PCO2 are in reverse direction, so it is respiratory alkalosis. How about the bicarb? Now calculating the expected pH from acute respiratory formula. So 7.40 plus 0.164 equals 7.56. What's the actual pH? 7.55. So almost the same. So it is uncompensated acute respiratory alkalosis. The kidneys have not come into effect at the moment. ABG 4. Step 1, pH 7.15, so downgoing, acidosis. Step 2, pH and CO2 directions. So CO2 is at 20, so downgoing. So both in the same direction, and Me for the same stands for metabolic. So it is metabolic acidosis. Now let's see the compensation. Apply the formula for metabolic acidosis. Expected carbon dioxide is 1.5 into bicarb is 8. So 12 plus 8 equals 20 millimeters of mercury. What's the actual carbon dioxide on ABGs? 20. So fully compensated metabolic acidosis. Now let's see the anion gap here. So anion gap is equal to sodium plus potassium minus chloride plus bicarb. So putting in the values, this makes 141 minus 103, so 38. Normal is 16 plus minus 4. So this is high anion gap metabolic acidosis. ABG 5, step 1, pH 7.28, so downgoing and acidosis. Step 2, pH and PCO2 directions. Carbon dioxide is 55.1 millimeters of mercury, so upgoing. So reverse directions, hence respiratory acidosis. Step 3, the compensation part. So expected pH for acute respiratory acidosis is 7.28, which is same as on the ABGs. So this is uncompensated acute respiratory acidosis. Now the next 5 ABGs will be more about the mixed acid-base disorders. Remember we said that if either of pH or PCO2 is normal, then it is mixed acid-base disorder. ABG 6. Step 1, pH is 7.49, so alkalosis. Step 2, direction of pH and PCO2. So while pH is upgoing, carbon dioxide is normal. This qualifies under third possibility of step 2, where we said that if either of pH or PCO2 is normal range, then it is mixed disorder. So if PCO2 is normal, then the direction of pH will indicate metabolic issue. So here pH is upgoing. So it is mixed metabolic alkalosis with secondary respiratory acidosis. Don't worry, as you practice them, you'll grasp the concept. So now ABG 7 and 8, in the first ABG, pH is 7.475, so upwards, meaning alkalosis, but carbon dioxide is normal. So again, when either of the two is normal, it is considered mixed acid-base disorder. So here, since carbon dioxide is normal, it is the direction of pH that will dictate the terms. So high pH meaning metabolic alkalosis plus respiratory acidosis. What about the second ABG here? Now pH is normal 7.43, whereas carbon dioxide is upgoing. So now when pH is normal and carbon dioxide is changing, the direction of carbon dioxide will indicate the primary issue. So here carbon dioxide is upgoing, meaning mixed respiratory acidosis with metabolic alkalosis. Get it? ABG 9. So what's happening here? pH is upgoing, so alkalosis, but carbon dioxide is normal. So now pH will dictate the terms. Upgoing pH means mixed metabolic alkalosis with respiratory acidosis. ABG 10. So pH in step 1 is upgoing, but carbon dioxide is still in normal range, right? So upgoing abnormal pH indicates the terms. So it is mixed metabolic alkalosis, and since we said that it is mixed, so mixed metabolic alkalosis with respiratory acidosis. ABG 11. So pH is 7.31, so downgoing. Acidosis. Carbon dioxide is 75, which is upgoing. So pH and carbon dioxide are going in reverse directions. So this is respiratory acidosis. As per the formula, expected pH in uncompensated acute respiratory acidosis in this scenario would be 7.12. In fully compensated case, the expected pH should be around 7.29. Now here's the kicker. Actual pH is 7.31, which is actually more than fully compensated pH. This means there is added metabolic alkalosis in the picture, right? That is causing pH to further come up even beyond the full compensation pH. So if pH on ABGs was 7.12, I would have declared it as uncompensated acute respiratory acidosis, right? If pH was somewhere between 7.12 and 7.29, that is between the uncompensated acute and the compensated chronic, then I would have declared it partially compensated. If pH was 7.29 on ABGs, I would have said it is fully compensated chronic respiratory acidosis. But here the pH was 7.31, which is safe to say rather overcompensation. And since there is no term as overcompensation, it is actually some underlying pathology here which is causing paradoxical metabolic alkalosis. Now this is also evidenced by the base excess, which you can see is plus 9.5. So additional base is in the body causing secondary metabolic alkalosis too. ABG 12. Now pH is going down, so acidosis. Carbon dioxide is going down, so same directions, hence metabolic acidosis. As per the formula of compensation for metabolic acidosis, the expected carbon dioxide level should be around 24.9, but actual carbon dioxide found on ABG is 15.8. So expected carbon dioxide is greater than the actual carbon dioxide fall. So see it this way. In metabolic acidosis, carbon dioxide should fall as compensation, right? So if 24.9, I'd say it is fully compensated. If carbon dioxide was somewhere between 40, which is normal, and compensated 24.9 values, for example 30, I'd say it is partially compensated, but here carbon dioxide is even lower than the compensatory limit. This is again another form of overcompensation or added secondary pathology. So I declare it primary metabolic acidosis with secondary respiratory alkalosis. ABG 13, pH is upwards, so alkalosis. Carbon dioxide is upwards, so in the same direction, hence metabolic, right? Now the formula for compensation of metabolic alkalosis, the expected carbon dioxide should be around 46.48. What's the carbon dioxide level on ABG? 50. So again, the actual carbon dioxide is even greater than the compensated one for metabolic alkalosis, hence overcompensation area. Hence, primary metabolic acidosis with secondary respiratory acidosis. ABG 14, pH is going upwards, so alkalosis. Carbon dioxide is going downwards, so reverse, meaning respiratory alkalosis. Expected pH for acute uncompensated respiratory alkalosis should be 7.45. The expected pH for chronic compensated respiratory alkalosis should be 7.42. But the actual pH on ABG is 7.57. Now, if it is respiratory alkalosis, we know that carbon dioxide level of 32.8 should have caused pH to rise around 7.45. Instead, it is risen to 7.57. Hence, there is added metabolic alkalosis going on as well. Now, this can be seen on base excess as well, which is at plus 6.9. So, extra base in the body is present. So, metabolic element to alkalosis as well. Now, these were a few ABGs. I started off with the simple ones and ended up with the complex ones. I hope you've got the idea of how to interpret the ABGs. Just take the worksheet and practice it on different ABGs in your ICUs. If there is any confusion, drop a comment in the comment section or share some ABG that you have found to be complex here or on the Twitter page. Thank you.